Okay, if you're just joining, welcome to the Sign IGOT webinar on pediatric diaphyseal femur fractures. We're going to be waiting a few minutes to get started. While we're waiting, we have a polling question that you can complete about your experience treating pediatric femur fractures. Okay, I think at this point, we're going to go ahead and share the poll results. So you can see where everyone's calling in from, a majority from Africa, but really participants from all over the world. A variety of experience, but mostly more experienced surgeons are joining, and with quite a bit of experience, it sounds like, treating these injuries. And C-arm available at least sometimes for the majority of participants. So with that, we're going to start the webinar with an introduction from Dr. Lou Zirkel from SIGN.
We are pleased to present the next webinar on pediatric femur fractures. The panelists for this will be Dr. Diaphyseal Shahab from Pakistan, Dr. Michael Segbefia from Ghana, and Dr. Colleen Sabatini from the United States, and Dr. Sanjeev Sabarol from the United States. We hope you enjoy this, and I look forward to hearing and seeing your comments. Thank you.
Well, thank you, Dr. Zirkel, for the introduction for the webinar. Hopefully everyone who's participating in the webinar has had a chance to review the pre-webinar material that came out yesterday, and is a nice didactic by Dr. Sabatini about the treatment of pediatric femur fractures. If you didn't have a chance to review it, it will be available after the webinar as well. We'll also be recording the webinar, and you can view the recorded webinar on both the IGOT portal YouTube page as well as the SIGN Hub. And lastly, before we get started, just a reminder that if you have questions throughout the webinar, please use the Q&A function, which will be at the bottom of your screen. If you submit those questions, we'll do our best to address all those questions throughout the case discussions. And with that, we're going to begin with a case discussion led by Dr. Diaphyseal Shahab from Pakistan.
Thank you very much, Dave. Thank you to SIGN and IGOT for this opportunity. So for this case-based discussion, I'll present the first case. Next slide, please. This case is of a 9-year-old girl who presented to us 3 days status post road traffic accident with a mid-shaft femur fracture. So this is a initial X-rays on arrival. So we would like to ask, next slide, please. We would like to ask about your preferred treatment of choice for this case.
That's great. I think we can share the poll results now. So it looks like a majority chose flexible nailing, but a variety of different treatments chosen. Any comments from the panelists about these results?
Yeah, I think, I mean, this is reassuring. As you said, Dave, this seems to be an experienced group of participants because this being a length stable fracture, I think, elastic nail seems to be an appropriate choice. But of course, there are other options. I did see 1 or 2 participants referring to a piriformis entry nail, unless I missed that. And, we can talk about that more as a group as we go on. What do the other panelists think about that? Dr. Diaphyseal or?
Yeah, absolutely. As you said, it's very reasonable. Flexible nailing is the preferred treatment of choice, provided that it's available and there's expertise to do so. I was also there were a few participants who also opted for spica cast. I wonder for depends on the availability of resources and all. Even although the guidelines are around 5 years of age, at times if we have patients around 6, 6.5, 7, who are quite lean, thin, and for some reason patients, the attendants or the parents of the patients are not willing for surgery, that's a very reasonable option as well. But for 9-year-old, it can be considered, especially in resource-constrained settings. Plate and screws, I think it's also very reasonable, especially provided, again, provided the implants and the constraints. And it can also be a very good option of with plates and screws of plating this fracture.
Dr. Segbefia, what do you think you would be doing for this kind of a patient in your setting?
I think I agree with the panelists in general. If we have flexible nail, obviously that's what we'll do. And of course, if the patients can afford it in our environment. I see some people have big traction. Usually at that age, they're a little too big for us to put the skin traction, which is maximum 5 kilos on them. So if I'm going to use traction for this, I probably will put in a Steinman's pin and put a bit more weight on it to be able to achieve that amount of reduction. Spider cast, well, of course, if it's a smallish 9-year-old may work. I'm not brave enough yet to use a piriformis entry nail at this age.
Yeah, a smart choice. And Dr. Sabatini, do you think this overall alignment, let's say this fracture heals in this position, is that acceptable in this patient in this age group or not?
Yes, actually, I think it is. You have probably just under 1 centimeter of shortening there, which is an acceptable amount of a leg length difference. So anything under 15 to 20 millimeters would be acceptable. You'd want to watch closely if you were treating it in a cast like this to make sure that you didn't have more shortening. But we do anticipate a small amount of overgrowth in children who suffer a femur fracture up to about 1 centimeter. So this might balance itself out nicely with allowing it to heal a little short and then having that overgrowth phenomenon happen during the two years of healing. But I do think that this would need to be watched closely if it was going to be left like this. In my hands, in a center that has resources available, this also would be a flexible nailing case. But I think in a 9-year-old, a lateral trochanteric entry nail or a rigid nail would be possible. I would strongly advocate against a piriformis entry nail just due to the very high risk of avascular necrosis of the femoral head in a patient who's only 9 years old. But I think the others are a viable option. And I think even though nobody picked external fixator, if that's what you have available, that too would be a viable option in this patient.
Great, sounds good. Let's just move on because I think some of these points will keep coming up, during the first couple of case discussions. Dave, do we have any Q&As or should we move on?
Not yet. So I think we can keep moving with what happened with the case.
Okay, go ahead, Fasi.
Yeah, so for this case, what we did was basically doing a K-nail or Kushner nail. This is one of the most common treatment modalities for treating pediatric femur fractures in our parts of the world, especially in an area where flexible nails are either not available or people are not very much experienced in doing so. There's one way of doing it. The classical way of doing it is basically to open up the fractured site and then putting in the K-nail from the fracture site proximally, taking it out proximally, and then reducing the fraction, hammering it back in. The eye of the nail is basically posteromedial. And that's the classic way of doing it, especially after doing a couple of sign nails and doing it with treating fractures with closed reamers. One modification that we did to this was putting in a reamer, reducing it close, and then hammering it down. That's our modification. But again, like in this case, we were able to do it closed. Again, depending on the implants, that was one option that we had, and we did it, and it had a very good results even at 9 months. For the patient presented after the first follow-up, came back at 9 months, and as you can see, even at 9 months, she had the skin staples on proximally. So that was at 9 months.
That's great. One question I have for the panelist. This definitely looks great and healed beautifully. How do you control rotation? Do you do anything? This was length stable, and I think you had nice sort of cortical reed, and it looks, very well aligned in all planes. But how do you gauge rotation that it's not mal-rotated? And do you do anything different? Let's say if you have this kind of a nail with no locking options.
Well, for proximal, if we are reducing it by open means, one guide is the linea aspera that we can judge, and it is kind of difficult, challenging if we are doing it closed, and actually at times it's very difficult to do so. But in pediatric fractures, we can have a little more leeway in terms of rotation. But yes, as you mentioned, it's very difficult to assess it close, and even without an image intensifier, it's very difficult. If it's open, we can do it with the linea aspera.
Great. Yeah. And I mean, sometimes I don't think this patient will need a cast supplementation, obviously, but for some of the elastic nail patients, where again, you cannot control rotation, I think sometimes just a couple of weeks of a cast, a long leg cast, can help sort of guide the rotation. Any other tricks from the panelists or any other comments?
I was just curious with a straight nail, I guess there was the concern about the piriformis and the blood supply. Are there any if you're using a straight nail, which technically would start in the piriformis, are there any pearls? Do you start this more, even though it's a straight nail, do you intentionally make it a more lateral start site just to avoid blood supply issues?
Yes, absolutely. Even with this nail, because we very rarely do these implants. Mostly it's either pediatric nail or the sign nail. So one way of doing it is to have the entry, making the entry point a bit lateral. And as Sanjeev mentioned, we do normally do give cast for about 3 weeks, because with kids, you're never sure about them, like they adhering to the treatment protocols. So even if you say them to non-weight bearing, you may be, when you come to the rounds after surgery, they might be walking. So you're never too sure about that. So giving a cast for about minimum 3 weeks is our preferred method also.
Great. All right.
Well, for us in the past, when we used this for adults, for when we didn't have the locked nails, we put maybe one screw up, one screw down, and screwed against the nail, against the bone, to give it a little bit of stability. It wasn't the best, but in the absence of locked nails, that's what we had to do for the very unstable ones. I suppose that if I'm pushing the wall in a case like this, I probably will go back to that old method.
Yeah, that's interesting, Michael. So just so I'm clear, so you try to decrease the space in the canal by putting a screw, just obliterate the canal kind of around the nail. Is that right?
Yes, and it pushes the nail against the inner cortex of the shaft, just so it minimizes the rotation. But since we got locked iron nails, I haven't had to use this method.
Yeah, that's good to know. That's a good bailout. Great. All right, so let's go on to the second case then.
So the second case is about a 6-year-old boy who presented to us 2 days after his road traffic accident. And as we mentioned from the pollings of the first case, the most preferred method of treating these fractures is by a flexible nail. And this patient was treated by a flexible nail. Can we move on to the next slide, please? So, but unfortunately, the nail was not, we did not have the appropriate type of nail, number one, and number two, the surgeon also did not have the proper expertise of doing so. So he was operated elsewhere. And as you can see, from a very simple fracture, now he has got a very complicated or complex type of fracture. So most probably while inserting the nail, which again, it's a very big nail compared to the diameter of the shaft. So probably while making an entry, what would have happened would have been that the entry would have gone, then the nail would have hit the lateral cortex, and there was a sort of a blowout of the lateral cortex. And also while doing it, there was rotation or malalignment of the distal fragment also. He was able to put in a nail. So this is how he presented to us after 2 months after his initial surgery. And so what can we do now?
Percy, before we move on to the poll, let's just spend a couple of minutes on this
Okay.
X-ray then. And you mentioned the mismatch between the nail and the canal. So can you or any of the other panelists help guide us? Like, how do you, let's say you're planning on doing an elastic nail, which I think is an appropriate choice for a lens stable fracture like this. How do you preoperatively plan in terms of choice of the nail diameter? Either you or Michael or Colleen.
So we
Go ahead, please.
I haven't done a case of the flexible nails, so I'm not a proper person to answer. But what I have understood is like you have to have at least half of the diameter of the nail to be so of the diameter of the bone should be the same size of the nail. Is it true, Colleen?
Yeah, so the goal is 80% canal fill with flexible nails, and you want to use 2 nails of the same diameter. So in terms of pre-op planning for these, for flexible nail cases, you want to measure the isthmus of the femoral canal to decide what your canal size is, and then I multiply by 0.8 and divide by 2, and that tells me what nail size I can use. So the overall goal is 80%. Sometimes based on that math, you can't, and you only have certain nail sizes to choose from, right? They go up by 0.5. So you often have to round down as opposed to up. And so although the goal is 80% canal fill, we do have studies that show that you don't need, you don't always need 80% canal fill, but that's what we're going for. If you try to do more than 80% canal fill, it can be very hard to pass the second nail up, and the nails get stuck on each other, and it makes the maneuverability of the nails quite challenging. And so that sweet spot is 80%. And again, 2 nails of the same diameter is really important in terms of the principles of flexible nails, with maximum spread at the level of the fracture. So they come up and then cross, and you ideally are having them cross below and above the fracture with the maximum spread of the nails at the level of the fracture. And that helps maximize stability of the construct.
That's great. Thank you so much for doing that. Yeah, and so again, it's not a canal filling operation, unlike, let's say, the solid nail case that Fasi presented earlier. And again, there are implant material choices, stainless steel, flex, and titanium. But honestly, I think either material works. And sometimes you can, if you have a long enough Steinman pins, you can also pre-bend them. And I think pre-bending is another thing that we do, unlike, let's say, the rush nail that some people have used in the past, that you got to pre-bend them, like Colleen said, in terms of the bending, etc. I see a message from Dave. Yeah, that may be a good spot to ask. Well, we have a polling question here. So should we just go to the polling question next? Go ahead. Go ahead, Fasi. Why don't you go through that, please?
Okay, so
yeah.
So the poll question is, what can we do it now? He presented to us 2 months after his initial surgery, and with this X-ray. So what are the treatment options we have? Either we continue with same and keep him in a cast, or we remove it. And after removing, should we apply a cast, or should we go for any other treatment option? For example, flexible nail again, or we revise it with the external fixator. We open it up and revise it with a plate, or we revise it with a nail.
It looks like a majority of participants chose to remove the nail and revise with a plate, but pretty universally revising with some other form of fixation. I guess the second most common was actually revised with flexible nails again. So perhaps there are some comments from the panelists about those different options.
Okay, when I look at the this particular case, I mean, the lateral cortex is blown out completely, especially of the distal fragment. Plating this is going to be tricky, given that the screw is going to be pretty much close to the growth plate. So perhaps that will be low on my list. Okay. I have a feeling, because when I look at the tip of the nail there, I have a feeling that it's very close to the skin. It probably is puncturing the skin. So the risk of infection has already been introduced in this case after this period. So that's also going to be one of my considerations here. So I think that, and even going to put in another flexible nail, because the lateral cortex is gone. I mean, I'm not going to get that effect that Colin was describing about the blow-up being around the fracture site. I am inclined to use an external fixator for this. Okay, that'll be my first choice. Use an external fixator for this particular one. Perhaps my other choice would be to remove the nail and then put the patient in traction and allow the soft tissue to heal and so on. I think those will be my main methods.
And while you all are discussing, we do have a question from Dr. Akure in Uganda who asks about the possibility of infection. So I'm wondering if you all could comment on whether you need to work that up, how you would work that up.
Yeah,
go ahead, Michael. Sorry,
yeah, when I even look at the lateral cortex, it's a little sclerotic. So I'm not inspired by it. It's possible that there's already some element of infection in that fragment. But of course, once you take out the nail, you're going to culture and do stuff to see how to check the stability of the place. But infection is also is a big risk here, given the tip of the nail where it is sited.
Right. So Michael, you're leaning towards taking the nail out. Would you realign it and then put a fixator on? Is that the plan?
Yes. Once I take the nail out, I will try and stretch it to length as much as possible. I know by now there's going to be colors, there's going to be fibrosis of the muscles and so on. But I'll rather deal with it, let it heal first. And then I know that, okay, I may have some length issues and deal with the length issues later when I know that the place is not, there's no infection at the site. So that would be my approach.
Yeah. So, okay. So, and this is what, 2-3 weeks out, right, Tracy?
2 months.
2 months. Oh, yeah. So, Michael, what do you think are the chances that this is going to move, without further sort of, I guess?
It's not going to move. It's not going to move after 2 months with all the fibrosis. And then I'm sure there'll be some colors there as well. It's not going to move much, but I'm happy to fix it inside to let it heal, and then deal with the consequences of that shortening later.
Okay, fair enough. Colleen, do you have any other comments or thoughts?
No, I would just, I absolutely agree with Dr. Segbefia that I'd be worried about infection here. I mean, so obviously clinical examination of where that nail is coming out medially. If it does have any skin over it and doesn't look concerning, then I would be less concerned about doing any kind of internal fixation option. But based on that x-ray, it does look like it's coming out of the skin. And so I would be hesitant, particularly since it's probably been out for at least several weeks of the last 2 months, to do an internal fixation option. So I do think that I agree with the idea of removing that nail, doing a formal IND of those medial soft tissues to make sure that we reduce our risk of infection there, and then to improve the overall length and alignment. And I think an external fixator as a temporizing measure would be very reasonable. And in fact, it could be your definitive treatment in this situation. If that nail is not out of the skin, which again, I don't think that's the case, but if it wasn't, then I would be much more enthusiastic about internal fixation options, such as, I think you could do revision flex nails here. It would just be challenging, but why not do, because it's a 6-year-old. I was about to say, why not do an antegrade intermedullary nail, but it is a 6-year-old, so we would not want to go through that greater troch apophysis. But another option which we could consider is an antegrade flexible nail distal to the greater troch, and then another nail from below. So there's a few different options there. But I think if it is truly exposed, which I think it is, then an IND and a stabilization with an external fixator would probably be the safest, most prudent option.
Great.
Or actually, if you could even theoretically do some sort of cast to the child. Is another option.
All right, so Fuzzy, do you want to tell us what happened to this child, please?
Yeah, so for this patient, what we did after, like, patient did not had, he had the nail protruding out from the skin on the medial aspect. And before going in, we did had a CBC count, ESR, CRP, and he had no infection. And we moved in, and what we did was we simply took out the nail, gave traction, and applied a spica cast for about 3 weeks. Because as mentioned by the panelists, we had considered other option as very difficult, to plate because of the big anterolateral piece. And even with a nail, it's quite difficult because at the very distal aspect, just above the physis, there is not much space for the nail to hold in place. So what we did was, we initially, as a first stage, we thought of just going in, removing in the nail, and then applying traction and putting him in a cast for about 3 weeks time.
Fuzzy, can I ask you,
next slide.
I'm sorry, was the
Yes,
traction skeletal traction or skin traction, and for how long? Or did you just put it?
No, so basically, I'm sorry, I just missed that. It was not basically giving him traction for time. It was basically just in the OR, removed the nail, gave him traction on the table, and then we applied the cast.
Okay, so manipulated in the operating room to get
Yes.
a little, okay, fair enough. And I'm sorry, what kind of a cast? A spica cast, you said, or a long leg?
It was spica cast. It was long spica cast.
Okay, single leg. Okay, let's go to the next slide then.
Before we're going, I just have 2 quick Q&A questions before we went too far. The first one is about the use of the signed pediatric nail as your revision option. And so Dr. Sabatini, you kind of addressed this with the comment about the age of the child and inserting a nail. Perhaps elaborate on that a little bit, what the issues are with nailing in a 6-year-old.
Yeah, so in the studies that we have available and sort of how we think about what implants are appropriate at what age. So the greater troch apophysis is contributing to important growth of the proximal femur, including the femoral neck, up to about age 8. And so if you take out your greater troch apophysis under the age of 8, you can have consequences that impacts the overall proximal femoral anatomy. And we like to avoid that. And so we do not, like me personally and other pediatric orthopedic surgeons that I work with, do not tend to put anything significant in size through the greater troch apophysis until over age 8. Because at that point, the greater troch is just contributing to appositional growth. And so we don't tend to worry about proximal femoral deformity in the over 8-year range. Sanjeev, would you like to add to that, your thoughts?
No, I think that's right. And again, there's like variations in where in the greater troch do you start, like, let's say a solid nail. And you again, you got to keep in mind, it's not just the guide wire, it's when you end up reaming or over reaming proximally. And like we've said a couple of times before, you really want to avoid going into the piriformis fossa because of the retinacular vessels that supply the proximal femoral epiphysis. And then that's a disastrous complication of osteonecrosis of the proximal femur. So yeah. And I did like, Colleen, your suggestion of, let's say, doing one retrograde and one antegrade nail, which may not be applicable right now in this patient, but I think that's a great option, especially when you have a more distal fracture. And then, you know, it's a little counterintuitive, because in the adult trauma world, and Dave can testify to that, if you have a more distal femoral shaft fracture, the go-to then, or the preferred method, is a retrograde entry. In children, it's just the opposite because of the physis. If that, sorry, if the, I'm so sorry, if the fracture is more distal, then doing a more proximal to distal entry is actually preferred, because you can get further down into the distal metadiaphysis of the femur. So that's just another thing to think about. So, and you don't always have to put, you know, obviously you can't start a medial entry, so you only have to do a lateral entry with the elastic nail, but you could do like a C and an S shape if needed. Okay.
Maybe Fasi could comment, just because he probably has the most experience with the pediatric sign nail, why you did or would not approach this with that implant.
So yeah, so the very first thing was because he had a very big anterolateral fragment, and with that he had his distal femur basically had very less support for the nail. And as you know, the fin nail does require it's a canal fitting, so it needs to fit in the canal. So even if the canal it's compromised because of the big anterolateral piece, so we thought that it would not be able to hold it in place. So one, and secondly, he had this deformity. So we thought that if we can get away with this by removing it and applying traction, and once if he still has a problem, then we can go in for the second stage, and then his anterolateral piece would have healed. So then we could have gone with we could have an option of nail at a second stage. But in the first stage, because of the huge piece, it was very difficult for the nail to hold it. And also the problem with the pediatric nails is the size. It's mostly in 20s and 40s, 40 mm. So it's very difficult to have the exact appropriate size for this fracture. So we thought of going in as the first stage of removing it.
Okay.
That's great. And then the last Q&A question before we move on is just about should you open the callus if it's not moving? And so it's sort of a question of, is this alignment acceptable, or, you know, so what are the panelists' thoughts on taking this down and trying to realign the fracture?
Yeah, I mean, does Fasi or Michael want to start?
Okay, yes, I'll come in. I'm not sure I want to do that now, except if I'm certain that there's no infection. If there's no infection, then I will do that. But if there's an infection, I want to treat that infection first before I go to the next stage. Even if it's not scaled here, I'll say that there's an overlap of about 2 centimeters. Okay, and if I can get it to heal in this position, I think that with an overlap of 2 centimeters, I know that in the future we'll gain about 1 centimeter or so. So I'll not be too interested in trying to move the colors. But when I look at it again, it's gone into some element of valgus as well. So whatever it is, I think once the infection is settled, I'll probably look at correcting all of that.
Yeah, Colleen, any other thoughts?
I'd love your thoughts, because I've been doing more talking. So since you are our deformity person, what would you say to accepting this amount of valgus malalignment?
Yeah, so I think as we all know, you know, if anything, the deforming forces for a fracture like this are to push it into varus and procurvatum, or apex anterior, just by the muscle pull. But what's also interesting is to look at the third plane, which is rotation. And if you look at your right-sided picture, you got nearly an AP of the distal femur and nearly a lateral of the proximal femur. So there is some degree of malrotation, at least suggested based on these x-rays. Having said that, I think this is where going back to clinical exam also is important, because even if this is malrotated by some degrees, the question is it clinically significant, and how much arc of rotation do they have on the other side? Let's say the left side, which is the fractured side, is malrotated externally. But if this child has enough internal rotation to compensate for that if when he's standing, his foot's still pointing in the right direction, I personally would tend to leave it and watch it. Now, there's soft callus there. So, like Fasi did, if you can manipulate it a little bit and cast it, in some kind of a corrected position, although not perfectly aligned, I think this is quite acceptable. And then again, talk to the family about a possibility of a future surgery, either for length or alignment or both. But my gut is, and I'm cheating because I kind of know what happened to this child, but would be that he'll be okay. So, but needs longer follow-up, right? So let's move on then, and just give us just final follow-up. Yes, please go ahead.
Yeah. So I would just like to ask the panelists, because I'm not an expert in flexible knee and I don't have much experience. Just for this case, the reason for this malalignment and iatrogenic fracture, was it because of a very large size nail, or was it because of less pre-bent in the nail, or was it a point of the entry point wasn't proper? So what was the main reasons that it went into this scenario?
Elaine, please go ahead.
Yeah, no, I mean, I think the number one, all of those things might have been at play, Fasi, but I think the number one issue is just the very large size of that flexible nail and it not being bent ahead of time, right? So when you have, that was a very big nail for the size of this child, because again, remember you're going for 80% canal fill maximum, but split between two equal sized nails. And that nail was 80% canal fill with one nail. And so it's not surprising that without a nail being bent more at the tip, if you can go back one slide just so we can see what the nail looked like. So it doesn't look like there's any type of additional bend to the top of that nail. And so it goes like the nail is actually straight, just with a small tip at the end. So many times when you put these in, you do have to pre-bend them to get the right contour to come up along the wall. And so I suspect what happened here is that just given the rigidity of that nail based on its diameter, without any proximal bend to it, that it just blew out that whole lateral cortex due to the size and stiffness of the nail. They surprisingly were able to get it up into that proximal piece, but when you've blown out that whole lateral wall, you get this problem, right, where then that shifts and the whole thing collapses down in terms of the construct. And so I think that this is a consequence, first and foremost, of the nail size and therefore stiffness, the lack of pre-bending, and then just not using proper, like the single nail technique is not ideal for this fracture with flexible nails. Again, it's a 2-nail system. And here, if you only had this one nail and you were able to get it across, then you could have supplemented with a single leg spica cast to hopefully avoid this problem. But given the lack of external support to the femur and this construct with that blown out lateral wall, it's not surprising that it settled into this position.
Yeah.
Sanjeev,
unfortunately, we do not have the first X-ray. I agree with all that have been mentioned, but I think because that metal could not bend well from the beginning, it cracked the cortex. Because if you look at it, the crack is not at the narrowest point. The crack is actually quite distal. It's almost like at the entry point. So from that point on, it started lifting up that cortex because it didn't have the bend that would take it to the opposite cortex and then slide back in. Because when you look at the proximal proximal fragment, you see that this lateral blowout is distal. And I think that it might even have happened before the nail got to the isthmus.
Oh, absolutely.
Even though I'm not sure a second nail that size would have gone through the isthmus.
Yeah. You know, but it's good to, sorry, Colleen, finish your thought and then I just have
No, I was just going to say, no, it absolutely, I think that's what I was saying, is that it blew out the lateral wall on insertion because it went in as like a straight nail and it was so rigid that it didn't turn the corner. So it probably blew out the cortex, which is why it's surprising they were actually able to get it up. But yeah, I think that this, you see this, right? Whenever you put a nail, one of these flexible nails in, you can blow out the medial wall too with that lateral nail, if you're putting in too rigid of a nail and not coming around the corner appropriately. So that's why pre-bending, pre-contouring is really important and helpful, and not using too stiff of a nail.
Yeah, so I think we've all been in a similar situation where, you know, something happens that's unanticipated. So if this was to happen to one of us and you've got this nail and you've sort of, you know, comminuted opposite, I'll just tell you a couple of thoughts that come to my mind. One is to, of course, like we said, we could downsize the nail and or put a second nail from the medial side, but then spin it halfway so that it catches the lateral cortex. So like do a C and an S from a medial entry. Another salvage option is, like we were talking about X fixes before, where you could do a hybrid with what is called a fixator augmented nailing. And we've sort of written about that too, where, you know, you've got a nail and you don't have enough canal, or for some reason you cannot put a second nail in, elastic nail in, then you could just supplement it with a very simple 2-pin external fixator, making sure the half pin doesn't touch the intramedullary nail on the inside, so you minimize the chance of infection. And that's like another mobile way of treating something like this as opposed to a spica cast. But I think it's dealer's choice, but I think it's good to have other options for situations like this. I think we should move on for the sake of time though. All right, let's go.
So for this case, we just remove the nail as mentioned. We gave him a 1.5 spica cast. He came to us after 2 months, and he was basically all right. He was ambulant, and he had a limited range of motion for around 30 to 40 degrees because of being in a cast for about 5 months till now. So, and he was happy. The parents were happy. So we decided not to pursue with the second case, with the second surgery, and he was all right. And this is his final X-ray about 1.5 years down the line. I saw him yesterday also. He has slight limitation in flexion. It's about 110 degrees, and he's fully mobile, and he plays for soccer, cricket, and he has no complaints till now. He had a slight mark on the nail entry side, which according to him gives him pain on and off, but other than that, he was asymptomatic.
Yeah, that's beautifully done. And I mean, I think it just goes back to our polling results to say that, well, it's okay to sometimes go conservative. And somehow when you look at the lateral view, I think the rotation doesn't look that off. So you probably either manipulated it or it remodeled or something like that. Or maybe
it was manipulated during the case.
Okay.
So, and we bring it out to length, and then nature healed itself.
Beautiful. Excellent. Should we then move on to our other options? And to see if you want to start, and then, you know, I can show some other sort of just quick cases. Go ahead.
Sure. This is our main go-to implant that we normally use. This is a case of a 10-year-old who had a long oblique mid-shaft femur fracture, and we went in with a sign fin nail. Basically, the sign fin nails were not basically designed for treating pediatric fractures, but in some parts of the body, as in ours, the canal diameter was big enough to about 7 mm, 8 mm. So we were able to pass in a 8 mm fin nail. And as we have mentioned, if something that's done properly in pediatric fractures, they do heal well. And as you can see, with successive follow-up visits, the fracture was very well united and very well healed. And as you can see, the implant was holding the fracture, and the fracture healed. So this is one option of treating pediatric femur fractures, mid-shaft femur fractures in children. Next slide. This is another example of a case that this is a signed pediatric nail. The signed pediatric nail comes in. It's basically was initially designed for using for pediatric fractures. The difference between this and the fin nail is about the entry as well as the shaft, which is much more narrower in this pediatric nail. This was one of our initial cases in which, as you can see, the nail was the fracture was reduced well in the initial surgery. But as we said, the patients are not compliant, and the kids started walking straight away. Luckily, he just had a bend which did not break. He presented to us at 3 weeks. So we augmented it with a spica cast, and we kept him here for 3 more weeks. Next slide. And luckily, he healed pretty well. And also luckily for him, the nail was strong enough and it did not break. And we were even at 1 year with the bent with the nail was strong enough to hold the hole to fracture as well as the nail itself. And once we removed it, we did remove the bent nail without any issues, and also the fracture healed pretty well. So these are options for treating pediatric fractures with a signed nail, with signed pediatric nail and a signed fin nail.
Great.
See, can you just comment on the diameters and how you choose between those different options or what the ranges are?
So basically the way we choose is once we do an entry, we use the reamers, and if it's even if a 7 mm is going in very, we have a 6, we start with reaming with 6 mm, 7 mm, 8 mm. So in patients around 10 years and above, we very rarely use pediatric nails. We tend to use fin nails, because fin nails start off with 7 mm, 8 mm and onwards. For children who are around less than 10 years of age or who are quite thin or have a very narrow canal, we prefer using the pediatric nail because it's more of a 6 mm nail. And we do have there is an issue about the appropriate length, because most of these sizes come in augments of 40 mm. So at times it's either very short or it's either long. And so then we have to, depending on the fracture, we have to change to another nail option. Like from pediatric nail, we can choose for a fin nail, or if not available, then we can go for cushion nail also.
Great.
Great, thank you.
Yeah, and I mean, so I guess 2 things come to mind. One is that you've got now the option of locking, at least proximally, which is good for rotational control. And like you showed beautifully in the last case, that you may have to sometimes supplement, let's say, pediatric sign nail with a cast just for, bending forces. One other question, do you remove these nails routinely or only if it's a problem?
Well, it's more of patients or parents' preference of removing implant. We do have a lesser threshold for pediatric implants because of their bone remodeling and with their proximity to growth centers. They can have a problem with overgrowth, and then it becomes very difficult to remove. Last week we had a case who had a K nail done when he was 5 years old, and now he was 19 years old, and his now the nail is proximally, it's at the subtroch level, and distally it's impinging on the anterior cortex. So it was very difficult to even to decide how to do it. And he has been to about 7 different surgeons, and they have given him different options. And so, yeah, so when the fractures, even when the patient comes to us, even at 3 weeks, the first question he asks is, when are we going to remove the nail?
Got it.
So,
Smart.
yeah, so that's more like, you can say, a regional way. The patient do want to take the nail out, and we also have a lesser threshold for removing the pediatric implants.
Fair enough. Okay, so we'll just quickly run through some other implant options. So we covered the entire spectrum. So this was, when I started practice way back, but it was an interesting child where one side was length unstable and the other side was length stable. And these, so like we were mentioning earlier, external fixation still is a good option, especially for the length unstable ones. And then back in those days, we had the Ender's nails. And there again, you can have some control of rotation with that eyelet that the Ender's nails had, with a small screw through the eyelet to control rotation. Next slide, please. So this is one other option, and you can see on that right picture where the arrow is pointing, to a length unstable comminuted spiral fracture, which goes pretty proximal. And here we used a different option and just did it with fluoroscopy and an external fixation. Next slide, please. And again, you don't need to use this exact external fixation device, but just goes to show that even with, let's say, if you were to use a monolateral fixator, that's an option. And since this was a slightly older child, we could put a half pin through the greater trochanter and stayed away from the piriformis fossa, didn't have to open the fracture site. Of course, it's cumbersome to walk around with an external fixator, but this again is another option if you have fluoroscopy available. Next, please. These, I think, are more recent cases, a 6-year-old length unstable fracture. Next, please. And here we used a submuscular plate. Again, it's not a very hard operation once you understand how to pre-bend the plate a little bit and you have the right tools and techniques. And you can think of it like an internal external fixator where you span the fracture site and you don't have to do an entire open reduction and you leave the soft tissue envelope intact around the fracture site. So it's a more biologic treatment for young children. Next, please. And then this was an unfortunate case that was referred to us way back and goes back to our point that we were making about a piriformis entry and why that shouldn't be done. So a 13-year-old pedestrian struck, nearly closed proximal femoral physis, but not quite, piriformis entry. Next, please. And unfortunately had what we were talking about earlier. He had a disastrous osteonecrosis of the entire proximal femoral epiphysis. So a bad problem that's avoidable for these patients. So please try to avoid a piriformis entry for exactly that reason of the retinacular vessels that feed into the proximal femoral epiphysis in these children, even if they're adolescents. Next. You can go on. Next, please. And I think this is sort of our final one where, like Colleen was mentioning earlier, you can also do a trochanteric entry nail or a variation thereof, where you avoid the piriformis fossa, and you can do interlocking nails to make it length stable. Let's go on. Next, please. I think if there, Dave, are there any questions from?
There is one question, and I don't know if I'm not understanding. It says for removal, hardware removal, any concerns about, and I'm not sure the word there, loans or ions release, loans release in case you decide not to or cannot remove the hardware. It might be my ignorance.
Maybe about ionic stuff. I don't know.
Ionis release?
Or ion, like
that's
maybe
not something I'm
like,
familiar with.
Like
I think it's like metallosis, like ion releasing, like leaching.
Oh,
into the
ions.
bloodstream.
Oh, got it. Yeah. So any concern for ion release if you can't remove hardware? Yeah, that makes sense. So any concern for ion release if you leave the metal in place?
Go ahead. Anybody wants to take a stab?
I don't have any concerns at all for that.
Yeah.
I don't. I mean, I suppose that here, if I were to add routine removal of implants, I mean, I won't have enough operating time. So I do not remove implants unless indicated.
Yeah, I think we feel the same, right, Colleen?
Yeah, I would say that this is very different than like a metal on metal joint, right? Where there's metal rubbing. We don't get that when it's an intramedullary device, so whether it be a plate or nails. So we tend to, if we remove hardware, it's not because of a concern for ion release in the future. So that would not be a concern for me.
Okay, I know we're, well, I think we're doing okay for time. So maybe I can request Michael Segbefian to present his case. Go ahead, Michael. You can unmute yourself, please.
Okay, so we can go to this. Yes. So this 10-year-old boy had a fracture, and he was taken to a traditional bone setter. And in our environment, we compete with traditional bone setters. And so they applied some cream to the skin, made some scarification marks, and he was there for a while. Then he got a fever and with a swollen right thigh, for which reason he was sent to us. Next slide, please. So we got his X-ray, and of course we did other tests, and we saw that he had evidence of chronic osteomyelitis. By the time we saw him, given the level of fever he had, we thought it was more of an acute on chronic type of osteomyelitis. His ESR, CRP were all elevated. In our environment, we have to check for sickle cell as well. So, what do you think that this boy had from the get-go, and what are our treatment options?
Okay, so I should have a poll question here for you that you can answer. And the question is, how would you manage this patient? And the options are open reduction with plate fixation and bone graft, open reduction without bone graft, IND with traction, IND with spica cast, IND X-fix, or IND with retrograde nailing, or other if you don't like any of those options.
Right. So again, Michael, just to reiterate, he never had an operation. He just had these manipulations done, and we don't really know what that involved, right?
Yeah, no, he had some scarification marks on the skin. So usually they grind herbs, and so they make scarification marks and then wrap it around the skin.
Got it.
But I mean, from the history, it was an open fracture from the beginning.
All right, well, I think we've got enough answers to have a consensus here. So by far the number one option here was to do an irrigation and debridement and culture, which makes sense with this concern for infection, and then external fixation. A few votes for traction and spica cast, but almost everybody went for the IND and culture as a primary part of treatment. So any comments from the panel on that?
I mean, that seems very reassuring. Tusi or Colleen, do you have comments?
My only comment, and I love casting, but my only comment against casting in this situation would be wanting to keep an eye on the wounds. And so perhaps not covering them up would be preferred. So that's why I would go external fixation in this case, just so you can continue to monitor the wounds and make sure that there's not, because there's both scarification marks. So you have to sort of keep an eye on all of the skin plus the area where you're actually doing the formal IND.
All right.
I agree with the same. But Michael, I just wanted to ask, just out of curiosity, do you do sickling for everyone as a routine pre-op investigation?
Yes. I mean, we've had a few interesting cases. And once the person is a sickle cell patient, in fact, no anesthetists who put a patient to sleep in this part of the world without a sickle cell test. Of course, if the person is a Caucasian, then that doesn't matter. But so long as the person is Black, that is a requirement.
That's interesting, though. So tell us a little bit more of how that changes management. Let's say if this patient was sickle positive, what would you do differently?
No, it wouldn't change the orthopedic management per se. However, anesthetists will keep a closer eye on this patient. For instance, after surgery, this patient will be oxygenated overnight instead of letting the patient go to the ward where the patient has recovered. So it is more of an aesthetic thing for us.
Okay, so like more fluids, and perhaps like when you're looking for inflammatory markers, sed rate, that could be falsely elevated, things like that.
Yeah, I mean, this patient, for instance, after surgery would not, even when he's recovered in the recovery ward, will most likely spend the nights in the recovery ward rather than go to the ward and lie on his own.
Another question on the topic of diagnosis and workup. There was a question about using MRI. I assume that that's challenging in many settings, but I'm just curious what panelists think about whether that's necessary to diagnose and treat this problem.
No, I don't think we needed an MRI for this problem. I think clinically it was clear that there was an infection there too. The limb was unstable. Clearly there was a fracture as well. And so if you put the history together, I mean, an MRI would not be necessary to make this diagnosis. Moreover, MRIs are quite expensive. It costs, I mean, beyond the reach of most. So in fact, the thought wouldn't even cross your mind that easily. If the thought crossed your mind, then it would mean that you're dealing with some ambassador's child.
That's fine. What about you, Colleen? You were going to say something.
No, I agree with Dr. Segbefia that there's not an indication for MRI in this situation. The original x-rays did not show any underlying pathology to suggest that this is a pathologic fracture, and it's otherwise, I think, based on history, clear that this is an infection. So I agree with that, and not too many ambassadors' children are we seeing, any of us. But the other thing I just wanted to say just about patients with sickle cell, just to recap, is that, as Dr. Segbefia said, making sure that they're appropriately hydrated is very, very important. And that's why knowing if they have sickle cell anemia is critical. Also, just if you're going to do an open surgery and you're going to have blood loss, then they might already be anemic at baseline, and then you're losing additional blood. And then, as he suggested, making sure that you have excellent analgesic on board, because what we don't want to do is in trying to fix this femur to precipitate a crisis for the patient. And that's why it's very important for the anesthesiologists and the surgeons to know if a patient has sickle cell disease. So in many parts of the world, we tend to think of Africa as the place where there's the greatest number of sickle cell patients, and that's true. But also through much of the Middle East, there's various forms of sickle cell disease, and I'm wondering if that's what Dr. Shahab was asking about, because I think it does tend to go maybe not as diagnosed and managed in some other places, and so we should think about that across all the countries in which there are higher percentages of sickle cell patients. So, Fasi, how do you manage that in Pakistan? Is that something that comes across your radar?
We have patients presenting to us with sickle cell, but the number is not too high. So we really do screening tests before that. Patients who do come, they have a history of family members, and then it's a disease going into families, and and they would tell us beforehand. But for a pre-operative screening, we don't do it. I was interested because if I see this, and the most probable bacteria that would come to my mind would be Staph aureus, MSSA, and MRSA, E. coli, and Pseudomonas. That would be like the 1, 2, 3, being from the most commonest. Would that change in being a sickle cell? Would Pseudomonas or Salmonella be on a higher than Staph aureus?
Well, I mean, when it comes to sickle cell, there's geographical differences and different reports about the commonest organism. Okay, when you read articles coming from Europe and North America, the copy seems to be Salmonella. But when you read articles coming from Africa, and as we speak, I mean, from Ghana, Nigeria, it seems like the commonest organism is Staph. Okay, all the others are not very common. So I remember I had to take that question out of the multiple choice, because if a candidate should read an article from North America, which finds Salmonella to be the commonest organism, and another student has read an article from the sub-region, which finds Staph to be the commonest organism, then you have a problem. That is one. Even within the sub-region, we have conflicting reports. Some researchers will find Salmonella to be commoner than Staph aureus and sickle cell. So basically, the approach here for any sickle cell, because you're not going to get a culture results for about the next 2 to 3 days. Okay, so we say once you're a sickle cell patient, cover salmonella as well. If you're a sickle cell patient, then you might not have to cover salmonella, but either way, you cover staphylococcus.
Yeah, I fully agree. I think that although like the teaching, like the buzzwords for sickle cell disease is salmonella, that even in the United States and in the European literature that talks about salmonella, still the most common bacterial infection in patients with sickle cell is staph. It's just that patients with sickle cell are more at risk than the general population with salmonella. And so that's the teaching, but it's still, when you look at the distribution of bacterial burden from infection in the population, still the most common is staph. So always treat for staph, as Dr. Segbefia said. And then if there's atypical features of the infection, then certainly salmonella is on the list and you wait for your culture data to come back. But that's unfortunately, our students here in the US are often taught incorrectly that, they think salmonella first, but really it's still markedly more common to have Staph aureus in sickle cell patients than salmonella. It's just that they're more at risk because of their relative asplenia. So.
Okay. All right. Let's move
all right,
on.
We'll get off sickle cell and back to femur fractures now.
All right. Good. Perfect. No, but that was great discussion. Okay. So Michael, tell us what you did.
So he did all the things that the candidates, or we did all the things that the panelists have mentioned. And we put in a monolateral frame external fixator. I mean, with the at debridement, it looked quite clear that he had we got a lot of necrotic bone. Okay, so we did that. We did irrigation. It looked good. I was actually quite happy with what I saw, and that is when we decided, okay, let's put on an external fixator. One, it satisfies a lot of the principles when it comes to managing this type of condition, and two, it might well be a definitive treatment if it should heal. So this is what we did.
Can I ask you a couple of questions here? So sounds like you debrided some bone as well. And then
That's
were
right,
you able to shorten and get it back to bone on bone?
Yeah, we lost, I think that post-surgery, I lost about 1 centimeter of that bone. We lost about 1 centimeter. But my aim then was to achieve a stable union first, and then we'll come and deal with the leg length discrepancy later.
Okay. My second question was, what do you think is the role of local antibiotics? Like, do you sprinkle any powder or put anything locally, both you and Fasi? What do you do something like that, or not really?
No, we usually, when we do the debridement, we irrigate with a lot of saline. Sometimes we even add a little bit of povidone, and we dilute it with a little bit of povidone iodine. Okay, at the moment, it's mixed. It's not regular for us in the sub-region to throw antibiotic powder into the wounds, But when people do arthroplasty, I know they sort of mix some and put in there. But we don't do that routinely. So I didn't do this. I didn't do that for this particular candidate. Yeah.
Yeah. Fasi, any other thoughts?
Yes, we in all infected cases, we do use vancomycin powder, especially if we have a culture report stating it's an MRSA. Recently, we've started using UV light also for infected cases, and it's basically in early stages. We have some encouraging results with that. One of the questions that I wanted to ask, like if we have sent it for culture and we are waiting the culture results, what are the antibiotics that would start with the patients once he's gone through in the OR and after in the ward before we get the culture results? Like we normally use cefazolin and tobramycin as a combination for all cases, especially like these. And if he already had a culture, then it's easy. And if he has been on multiple antibiotics and if he has a MRSA, then we start him on linezolid.
Michael or Colleen, or actually Dave too. Dave, you want to put in, what do you do in the adult world for something like that?
I mean, if you're just going for broad spectrum coverage, we typically would use something like vancomycin or tapetum. So we cover MRSA, all the staphylococcal species, but also gram negative and anaerobic coverage. But I'm not sure in the pediatric world might be a little bit different just because of the bugs that you typically see.
Yeah, and apart from that, vancomycin is extremely expensive here. So it's like Maybach. You don't put on a rough road. We reserve vancomycin for real stuff, if you know what I mean. So we are limited, but I think that it's interesting. I'll look at the results when I after this, because it seems to me that we are able to get them treated. I mean, for Salmonella, we tend to use ciprofloxacin for that, and for staph, we still play with first generation cephalosporin and sometimes clindamycin. You know, so those are the two main ones used for staph, and then Cipro for Salmonella. I mean, there was a time when Cipro came out maybe some 20, 30 years ago, when we had all these concerns about effect on cartilage and so on. So at the time, we were not very confident to use Cipro on children, but I mean, out of desperation, we didn't have a choice but to use Cipro, and that complication which was mentioned didn't prove to be accurate in our setting.
Yeah, I would just add to that, you know, there's been a big, I don't know if this is true in pediatrics, but there's been big trend towards oral antibiotic use, actually, earlier conversion to oral antibiotics rather than IV. And so once you actually have a culture result and you can do culture specific antibiotics, then as long as there's a list of, you know, the orally bioavailable antibiotics, we usually now, rather than doing a 6 weeks of IV, which is extremely resource intensive, just doing a relatively early conversion to oral antibiotics at this point.
When I was a student, then IV antibiotics will run for about 6 weeks. But now, I mean, I don't think there's anybody who will do 6 weeks of IV antibiotics. And the teaching has always been that if you start the IV antibiotics and then the fever settles and patient's condition settles, you consolidate it for 2 more days or so, and then you switch to oral. I think about 2 years ago, the New England Journal published an article where they even said you could start in the acute phase with oral antibiotics, and they compared it to IV antibiotics, and they found that outcomes to be pretty much the same. It made us happy because if you can give oral antibiotics, it's cheaper than giving IV antibiotics. Okay. But having said that, I've not been brave enough yet to see someone with an acute orthopedic infection and started a person with oral antibiotics. I always would start with the IV antibiotics.
Yeah, fair enough. Michael, I think we're all interested in seeing what happened to this child. So let's go to the next slide. What did you do? Tell us, please.
So we did this and mounted the external fixator after the debridement and everything, mounted the external fixator. And then a few months later, it failed. It literally fell apart. So, but by that time, the skin was good. There was no evidence of active infection. So it was at this point we said, look, external fixator has failed. Okay, let us go put a plate.
Oh, I'm sorry, I missed it. Did you say it failed or the stuff?
Well, it didn't unite. It got a non-union, and despite every attempt to dynamize the external fixator and so on, it didn't work.
Okay,
so
but the
we
infection,
had to.
Right, but the infection was controlled based on.
It was. It appeared to be under control.
Okay, all right. So please keep going. So what was the next step?
So I think this is where we should. So we decided to go and put a plate, and so we put a plate. And then
Right.
and that's where my nightmares began.
Yeah, but let me ask you a question, and maybe panelists can chime in. I know time is limited. What are the thoughts if you've had an X-fix for a few weeks, and then in the face of a history of infection, and then you put an internal implant? You know, there is this thing called a pin holiday, where take a fixator off, let things settle down, and then go back with a more definitive internal fixation. Does anybody feel there's a role of that or not? And did you do that in this case?
No, I didn't. I actually do support that principle, and we've used that a few times, even for adults. I think that I was under due pressure, and we just wanted to stabilize this the best way forward. And I remember trying to justify it. That, look, the fact that it's an infection doesn't mean there will be non-union. You can still have union in the face of an infection. Okay, yeah. So this particular thing violated many of the orthopedic principles. I mean, placing it violated many of the orthopedic principles. But I said, let us do
fair
that.
Enough. No, fair enough. It sounds like you did think through it and thought that getting stability, union was okay, and you could deal with infection if it ever flares up again. So I know we're a little short of time, but tell us where we ended up, and then we'll open up for questions.
Yes. So basically, the parents, I think, also had surgical fatigue, and they didn't want to come back to theater. They had family issues and so on. So at some point, about 6 months or so later, I thought I knew this had failed. So I was thinking of a plan C to use. And the parents said they were not interested in surgery. So they sort of made my work a little easier because, frankly speaking, I knew that this non-union was because of an infection. So I'm going to take this plate down. What was I going to put there? He was a little too big to fit into a hip spiker, as you saw in the picture. So I really, at some point, thought, look, if we take out this nail, I'm going to ream and I'm going to put in a solid and rigid nail and achieve that stability, and then bone graft it, and then pray that it heals, and then I will manage the infection if it should occur later. So because he refused surgery at that time, I think the next slide, please. So 8 months later, you see the gap is still there. At that point, I said to the parents, look, we have to do something now. They didn't mind me again, but they got lost. And I saw them about 6 months after that visit. And I was quite surprised. I mean, there's some truth about him there. There's a lot of shortening. He has about 3-point-something centimeters of shortening. Okay, and so that is what I have to deal with for him. But I mean, I'm surprised that it's united.
Yeah, no, that's good. I mean, I think one of the lessons here is that kids are a little different. They have better biology than adults for the most part. One other question, I don't know if you mentioned in passing, what about bone grafting when you went into plate? Did you think about it? Did you do it? Or if not, why not?
You see, when I have to take bone graft from children from the earlier crest, I'm not happy about it. But because we didn't have allograft, but if we had allograft, I would have used it. Because to go to earlier crest and harvest bone for kids, it's not something, unless maybe you're doing like an innominator osteotomy and you're already there. But otherwise, I'd rather use an allograft.
So see, what about you? What are your thoughts on bone grafting, autograft, allograft in similar situations?
In pediatric fractures, as Michael said, we have a higher threshold for getting a bone graft. Mostly if in such cases, there's a lot of callus around the fracture site. So we kind of chisel that out and use that as a bone graft. In kids, we are quite hesitant to go into iliac crest and take out bone graft from there. And in children, if the biology is good, if you clear out the infection, if they and you have a proper mechanics, they do tend to heal. So bone graft, in most of the cases, we in adults, if a similar case, we definitely do a bone graft. In children, we prefer not to do it.
Good, great. Any other thoughts, Colleen or Dave?
I think just in the
Okay.
interest of time, we're okay. Yep.
Yeah, all right. So is that the final slide or we have one more, Michael? Okay, yeah, I think this is actually a nice segue for perhaps our follow-up webinar, which we can do on pediatric deformities. And then, so this may be, the first of a couple of webinars dealing with the same thing, but this was a nice build-up talking about the acute management and kind of the somewhat of a delayed management of this child or similar children with femur shaft fractures. So Dave, I'll hand it over to you and thank the panelists. I think it was a great discussion of 3 cases.
Yeah, thank you all for all the comments and discussion. We do have some Q&A questions that I don't think we're going to have time to answer, but they're really great questions. So we'll try to address those by email after the webinar. I'll send those out to the panelists. So thank you everyone for participating. We're going to have some closing remarks by Dr. Richard Coughlin, the founder of IGOT. Thanks everyone.
Well, I certainly would like to thank everyone for their participation in this really outstanding webinar. Informative, fascinating, and truly a global panel. So to Dr. Shahab, Segbefia, Sabatini, Saberwal, and Dave Scherer, that really wonderful job in presenting challenging and fascinating clinical cases. So greetings everyone from the Orthopedic Trauma Institute here at University of California, San Francisco. IGOT is very pleased to partner and coordinate these activities with Sign Fracture Care. And currently we're doing bi-monthly webinars, and I'm pleased to see that we've piqued the interest of Dr. Saberwal to continue on with more interesting presentations. Please don't shy away, but give us your feedback and any suggested topics that you'd like to hear from us. And with that, I wish everyone a wonderful day, and we'll see you in the very near future.